Hello, massage therapy students. This is the asynchronous lecture for Patho 1 for Queensborough Community College. We're going to be going over the lecture. There will be a couple of items included with the lecture specifically to prove that you watched the entire video. There will be blanks on your homework assignment. You will need to write down the words that come as prompts throughout this assignment to make sure that you did, in fact, attend this class. What we're going to be doing in just a moment is I'll be sharing the screen just like a normal lecture. I will go through the conditions we need to know for this coming class, and there may actually be a quiz next week to confirm that you did the work. Now that we know what the parameters are for this, let's get started with our lecture. Everybody should be able to see the lecture listed here for conditions of the musculoskeletal system. We are building upon the items we learned last week. So, as stated before, there will be various prompts as we move along the screen, indicative of what it is we're going to be studying today. So let me just make the screen a little bit more full so you can see it better. Very good. Everybody should be able to see the items as they come across. For those of you writing along on question 4 on your page, the first word in question 4 is the word which. Please write this down on your assignment. Again, if you are found giving this information to anyone, you will be receiving a 0, and the person you gave the information to will be receiving a 0. Everybody has to watch this video for credit. So how many conditions are there in the body? We did a little intro to this last week, but we're diving a little bit further here. Over the next 2 semesters, you may cover more than 300 conditions of the bodies of your clients encounter. The most common conditions we're going to cover in this class, although I might throw in a couple of rare ones just because they might be fun. As we delve further into musculoskeletal conditions, consider whether it is more likely for a condition of this system to be indicated or contraindicated. Those generalizations, knowing that if something is a digestive condition, can you work on it or not? Is it a neurological condition? Can you work on it or not? These items help give you a better sense of the types of treatments you're going to be performing, and also New York State may ask those generalized questions for your own elucidation. Very good. Let us continue with conditions of the musculoskeletal system, and we're going to start off with one that we may have mentioned last week, de Quervain's tenosynovitis. Now, first off, what is a tenosynovitis? That is an inflammation of the tendinal sheath. I love this hand drawing here. You can see that there is a swollen tendinal sheath that specifically covers the adductor pollicis longus tendon and the extensor pollicis brevis tendon. That irritation leads to inflammation along the radial aspect of your wrist. Sometimes this condition may be related to things like, you might have heard the expression blackberry thumb, which literally using blackberries and pressing with your thumbs. That may cause a condition similar to this. As the name implies, the condition is an inflammation of the sheath of the tendon, and the 2 tendons I mentioned are listed there. This is a commonly asked question on the New York State boards. They love to ask about de Quervain's tenosynovitis. And the special test for this condition is called Finkelstein's, which is where you grasp your thumb inside of your fist and alternately deviate. If you experience pain along the radial surface of your wrists, that is usually a positive sign for Finkelstein's. What causes this? The etiology is repetitive motion or repetitive weight-bearing injury, depending on the source. Perhaps you're using your thumbs a great deal. Massage therapists take note. Perhaps you've been typing a great deal. This may also lead to some de Quervain's. Signs and symptoms include pain with radial deviation, bringing the wrist toward the thumb, swelling and tenderness with numbness and weakness with certain positions. There is the possibility of impingement with the radial nerve in this motion. Generally, when encountering Western medicine, they will often prescribe physical therapy, but they may also offer up anti-inflammatories like Advil or Tylenol, or corticosteroids in severe cases. They may actually inject steroids into the area. This is a musculoskeletal condition dealing with tendons. The disposition here reflects the consideration of doctors in our field. You remember when we talked about tendinitis, but tendinitis was a caution depending on its severity. Well, Frequently, doctors will prescribe massage for the treatment of de Quervain's tenosynovitis. Like any tendinal injury, when the condition is not acute, treatment is possible and indicated. Doctors will frequently recommend treatment for de Quervain's tenosynovitis, so the disposition of this condition is indicated. For those of you taking notes for our quizzes in the future, de Quervain's indicated. Very good. Very good. Next condition. Feel free to pause this video if you need more time, but we're going to press on significantly. The next condition on our list is called Osgood-Schlatters disease. Osgood-Schlatter is a type of bone growth that occurs due to quick growth of muscles in a not fully grown yet body, usually a teenager, which leads to tearing of the bone and scar tissue there. You can see that this tibial tuberosity is extra large. That occurs due to Osgood-Schlatters disease. Osgood-Schlatters disease is characterized as a patellar tendonitis at the tibial tuberosity in immature bone. The repetitive pulling of the quadriceps may cause an increase in size and development to said tuberosity. Most commonly found before the ages of 13, usually that pre-teen area is where we see Osgood-Schlatters develop. What causes it? Etiology for this is an indirect trauma of overdevelopment and repeated stress. Usually this is preteen athletes, people who are young people who are taking baseball, football, wrestling, gymnastics. They overdevelop their bodies, their muscles grow faster than their bones, and then the bones start to grow, which leads to some tearing. This can also be caused by some direct trauma, actually impact on the bone itself. Because we have more muscle building in the younger years with AMAB than AFAB folk, we're going to see this more significantly in males. This condition is also known as a tibial tuberosity apophysitis. Signs and symptoms of this condition: localized pain and inflammation. The more you do things with your knees, the more exercise with your quadriceps, the worse the condition gets. You will eventually develop a prominent and sore tibial tuberosity. That's what we saw in the image. Severe cases may lead to the tearing of the tibial tuberosity. Once torn, that disfiguration of your tibial tuberosity will remain for the rest of your life. It will merely look like an extra bumpy bump on the front of your knee, at the top of your tibia. Most common Western medicine treatment for this is to tell those young people, stop working out so much. Don't perform physical activities until your body's fully grown. Analgesics and anti-inflammatories may also be used, as well as a brace for the knee. Sometimes knee braces will be there to support said structures. Bottom line, can you massage Osgood-Schlatters disease? As with all tendonitis injuries, we're permitted to work on the tendons of the muscle in question when not acute. However, due to the specificity of the injury point, because that bone is tearing away, that process is tearing away from the tibia, a local contraindication advised for individuals with an active case of Osgood-Schlatters. This indicates as a local contraindication, LC, due to the fact that the bone may be tearing away from the structure. Severe cases of this may actually tear the tibial tuberosity off of the shin bone. Unpleasant. So we do need to keep that in mind when seeking treatment. Very good. Word 2 in our 4-word sentence. You remember the first word. The second word in that sentence is muscle. So you know what the first word is. The second word is muscle. Pressing on. Next condition on our list is torticollis. This is actually a group of disorders, usually 2 main ones. A group of disorders involving spasms of the sternocleidomastoid, or SCM muscle, also known as wry neck. Wry not meaning rye bread, wry meaning twisted. There are 2 forms of torticollis, the 2 main forms. Congenital muscular torticollis is a genetic disease, and one that we can't necessarily fix. The one that is due to misalignment and muscle activity is spasmodic torticollis, or ST. It's much more common. ST is also known as acquired torticollis because you develop it over time. It's also known as cervical dystonia. Etiology. Torticollis is either contracted by genetic means or non-specific trauma. Most commonly, it is caused by people who work at a screen where the screen is not directly in front of your head. You're constantly turning your head to get to the screen, kind of like I'm doing right now. And that constant turning leads to overdevelopment of one of your SCMs. Signs and symptoms associated with that are due to that excess activity, rotated or tilted head, along with pain, impaired range of motion, or local tenderness. The treatment for spasmodic torticollis is often physical therapy that will work to develop the antagonist muscles and stretch the agonist muscles so that your body more efficiently heals. Analgesics may be advised, as well as chiropractic for misaligned vertebrae. Dry needling may be used specifically for the pain. That includes acupuncture. And in extreme cases, they may inject Botox or botulism toxin into the muscle to stunt the muscle's activity to allow the neck to heal faster. I personally will avoid Botox treatment. I will go the other ways. Bottom line, can you massage it? When not in an acute state, torticollis responds well to massage therapy. Focus attention on trapezius, splenius, and of course, the sternocleidomastoid muscles. Cervical dystonia, or spasmodic torticollis, or torticollis of any variety, is considered indicated, capital I. Very good. As always, feel free to pause and go back through this and listen to the brief lecture again. Do also make sure that you are reading along in your chapter in your textbook. This is chapter 3 in our Werner textbook. Next condition on the list is whiplash. You've probably heard of this before related to car accidents. It's also officially known as whiplash-associated disorder, or WAD, W-A-D. Whiplash is a strain of the cervical spine and or a sprain of the local ligaments around it. These, of course, are the connective tissues that hold our vertebrae in place from C1 to C7. These may include fractures of the vertebrae in extreme cases, herniated discs, quite common, joint trauma, and possibly a concussion. My mother once got whiplash from a roller coaster, rather violent roller coaster that doesn't exist anymore. Can't imagine why. Most commonly brought on by motor vehicle accidents. Whiplash can occur in accidents as slow as 15 miles an hour. It can also be caused by amusement park rides, as I mentioned before, sports injuries, and for those of you who are fans of 90s grunge, headbanging. Headbanging can get you there. Signs and symptoms associated with whiplash. Pain with limited mobility. Possible trouble swallowing due to dislocations and inflammation in your neck. Radicular pain. Radicular pain, again, is radiating pain, usually down one side of the body. Possible breaks of bone mean that the whole body is contraindicated 72 hours after onset. Once whiplash has been identified by a medical practitioner or by the individual, they cannot receive massage for 72 hours. Now, why is that? This is often because the muscles of your neck will clamp down in order to protect against any possible broken bones. It is advised that your neck is x-rayed before you proceed with any kind of massage treatment. Certainly, no treatment is provided in the first 72 hours for massage. So that is why that is listed here. You may wish to make a note of this because New York State does love to ask that question. They ask, okay, client has a whiplash, how do you best massage? The correct answer is no massage for 72 hours. Very good. Generally, whiplash is treated with pain relievers, medication specifically, physical therapy, chiropractic, and osteopathic work. Massage is usually coming in toward the end of the treatment bottle, as we discussed in class 1, once you get to fibrosis. Bottom line, can you massage it? As I stated, it's fully contraindicated for the first 72 hours. After that time, and after the injury is no longer acute, light, conservative work may be done to address pain and improve quality of life. This means effleurage. This means lighter sweeping. Deep pressure work should be avoided. The disposition technically classifies as a caution, but it's a special caution-y caution. You don't want to work on this until the tissue is actually ready for treatment. Makes sense so far? Very good. Next condition along is adhesive capsulitis. You may have heard of this in other classes or from your own life. This condition is also known as frozen shoulder. What can happen with the glenohumeral joint, where the humerus here inserts into the glenoid cavity, is when there's an injury, you may develop specific adhesions around that joint capsule. This can lead to the joint not moving as freely as well. This is a movement-impaired condition of that joint and possibly the scapulothoracic joint with it. It's much more common in older clients and individuals with diabetes. People with inflammatory conditions are more prone to this issue. 3 stages: freezing, where you are losing mobility; frozen, where the mobility is gone; and thawing as the mobility returns. You may see that on an exam. Most cases of adhesive capsulitis are idiopathic, which means the cause is unknown. Usually an associated injury, almost always a rotator cuff injury is in play, and ischemia or systemic inflammation are likely causes. When my father got adhesive capsulitis, it's because he was playing baseball in his 50s and swung at something a little vigorously, and his shoulder hurt for probably 3 months. It was a long time for him to heal. Signs and symptoms: dull pain, which becomes worse. It can hurt while you're moving, or it can hurt just standing still, and the pain can radiate up to the neck and down to the fingers. Greatly reduced range of motion is the primary symptom, hence adhesive capsulitis. Early on in the condition, we advise medications. Later on, physical therapy and chiropractic are advised. So, where does massage fit into this pattern? As with all acute conditions, adhesive capsulitis is contraindicated when it's acute. Makes sense. Once the inflammation has been alleviated, deep work on the surrounding shoulder muscles, biceps, triceps, trapezius, supraspinatus, infraspinatus, working around the joint in a PDP protocol. That means proximal, distal, proximal. Has been proven to expedite the healing process. Care must be taken, however, not to push the joint function too quickly, lest the condition revert to some more severe impairment. You may see videos online where someone like Dr. Ben Benjamin is like forcing a stiff joint to move and forking it all over the place. He is a doctor. We are not. We will not stretch a joint further than its comfortable positioning. Therefore, this condition is considered a caution, CA, caution for range of motion, which we cannot encourage or facilitate. Very good. Very good. Pressing on. Third word. Word number 3 for your homework assignment is unlocks. You've seen the first 2 words. The third word is unlocks. Make sure you make a note. Next condition on our list is compartment syndrome. It's also known as chronic exertional compartment syndrome or exercise-induced compartment syndrome. This is a chronic condition, therefore not acute. If you are found with a client who has acute compartment syndrome, that is a medical emergency because it can lead to death. So we need to be careful of that. We're going to talk about more chronic injury, often seen in athletes in their 20s. The last time I saw it in someone, the individual was 16 years old. Compartments specifically are referring to aponeuroses and soft tissue structures that surround groups of muscles. Fascial compartments. Fascial compartments can swell due to overactivity and ischemia depending on whether or not good stretching has been done. We usually see this along the anterior leg involving tibialis anterior, extensor hallucis longus, and extensor digitorum longus. That would be an anterior compartment syndrome. That's where it's most likely in the body. Posterior compartment syndrome can occur, or brachial compartment syndromes in the arms can occur, but the anterior portion of the lower leg is most likely. Signs and symptoms with this condition include pain, tenderness, tingling, pressure, the sensation of pressure, as well as tightness. The more you use your leg, the worse this condition can get if it's anterior compartment syndrome. Treatment for this often involves pain relievers, analgesics. Stretching, highly advised. If there are issues with the muscles themselves, antagonist stretching or stretching of the calves for the dorsiflexors and vice versa are needed, as well as possible orthotics in the shoes for particular deviations. Significantly, overpronation can lead to this. Surgery may be an indication in extreme cases, especially if the condition may become acute. Bottom line, can we work on compartment syndrome? If it's chronic, yes. When not in active pain, this condition may be addressed. Friction, myofascial release, and vibration have all been effective techniques to treat this condition. Disposition here is a caution just because the severity of pain may be excessive, and we need to be observant about possible issues related to the condition exacerbating to a more acute state. Next condition on our list is shin splints. Excuse me. Shin splints. It is a non-specific term describing pain along the medial tibia. The pain can also occur on the lateral tibia. I'm just writing what the book says, but any pain along the shaft or diaphysis of the tibia could be referred to as shin splints. It is often bilateral, occurring in both legs, occurring mostly to athletes who run and jump, long jump, high jump, pole vault. If not addressed properly, it can lead to the development of a compartment syndrome. This is also known as medial tibial stress syndrome in some texts. Etiology for this condition, most often caused by overuse. Overuse, specifically athletes, basketball players are specifically prone to this. Other factors include overpronation, again, excessive rolling of the foot from heel to toe, fallen arches, which occur when a healthy arch begins to deteriorate, often due to poor footwear, and uneven surface running, i.e. roads. Road running is often a crowned surface, which is uneven. Signs and symptoms for shin splints: pain, tenderness, and swelling. The pain with shin splints can reach unbearable levels in their extreme. Treatment for shin splints is rest. They tell you not to work out anymore. Analgesics may be needed, and again, orthotics to address overpronation. Bottom line, what was the disposition for compartment syndrome? That was a caution. Disposition for shin splints is also going to be a caution. Again, range of motion treatments are noted as helpful, but be careful not to overstretch the tissue as it may lead to tearing. And here comes word 4 for our number 4 on our homework assignment. Word 4 is knee. Please note the question mark. Knee. Very good. Next condition on our list is plantar fasciitis. Plantar fasciitis, of course, inflammation of the plantar fascia. Real simple. Just read the words. Chronic inflammation of the plantar fascia is what we're talking about. This is common with athletes and individuals who wear poor footwear. This can lead to torn tendons and bone spurs, depending on where the pressure on the bottom of the foot is. This is most commonly going to affect males, folks who identify as male, between 40 and 70 years old. Why those folks? Well, people my age tend to think that they can be athletes like they once were. They'll go, oh, sure, I can do that mud run on the weekend. They end up working out too hard. They overwear their feet. and they develop plantar fasciitis. I've had it at a couple of points in my life, but I know how to treat it so it never lasts long. Etiology, caused by repetitive motion, doing things over and over again. Risk factors include flat feet, people with no arch. High arches, people with an excessive arch, like me. Sudden activity increase, there's that mud run on the weekends. Diabetes, people who are susceptible to it. Arthritis as you get older, and poor shoe support. Always make sure you're wearing proper shoes. You may need someone to help you, either usually folks at shoe stores are pretty good, but a podiatrist is a better fit. Signs and symptoms with plantar fasciitis: pain and tenderness, especially first thing in the morning, mild swelling, and pain does subside with use. So one of the things we tell you to do is possibly roll your foot out with a tennis ball first thing in the morning, or put your feet directly in sneakers straight out of bed. That can take some of the pressure off of your arch. Other Western treatments include rest, of course, analgesics and anti-inflammatories, drugs, that is, physical therapy, orthotics, and in extreme cases, a cortisone shot to the foot. Bottom line, can you massage plantar fasciitis? It is part of our treatment protocols. Massage therapists treat plantar fasciitis. When the tissue is not inflamed, myofascial release, trigger point therapy, and even standard foot massage techniques can provide reasonable relief from the symptoms of this condition and assist in the healing process. Plantar fasciitis is indicated for treatment. The next series of conditions are related to spinal deformations, some of which are common, some of which are acquired later in life, and some of which are genetic. We're looking at kyphosis, lordosis, and scoliosis. These are congenital spinal deformations of varying natures. Let's start with kyphosis. This usually affects the kyphotic arch of the back, which is the thoracic spine, or sometimes the sacrum itself. An exaggeration of that kyphotic arch is called hyperkyphosis, also known as hunchback, an excess curvature of the thoracic spine. Similarly, if you have an accentuation of your lordotic curves, either in your cervical or lumbar spine, we see that as a lordosis. If it's the lumbar spine, it's sometimes called anterior pelvic tilt or even sway back. The official name for that is hyperlordosis. Can these conditions have no curvature? Yes. However, curvature is normal for our spine, as that curved nature allows our spine to absorb shock when we jump up and down. What we would say instead, if there is no curvature, is that the spine is hypokyphotic or hypolordotic. Uncommon, but actually problematic, as it means there is more shock being done to the spine with each jump and step. However, if the spine deviates laterally, lateral deviation of the spine is referred to as a scoliosis. Scoliosis comes in three different flavors. It can be one-sided, which is called a C-curve, only one side lateral deviation. The deviation can go both-sided, left and right. That would be an S-curve deviation. It may not look like an S, but it's called an S-curve. That S-curve may actually go anterior-posterior, like a corkscrew. In those circumstances, it is called a helical scoliosis. Etiology. Most forms of these misalignments are congenital. You're born with a particular spine, you inherited that spine from your folks, you develop these conditions. Some forms of lordosis or kyphosis are exacerbated by muscular imbalance due to physical activities. Posture and disease are also contributing factors, depending on how you slouch and how often you slouch, and things like that. Signs and symptoms, we notice the deviations. However, pain is not usually a symptom with these conditions. It's possible, but it's not common. Western medicine treatment for lordosis and kyphosis, they will tell you to strengthen opposing muscle groups. For lordosis, they'll tell you to strengthen the abs. For kyphosis, they may tell you to strengthen your rhomboids, for example. For scoliosis, as long as it's less than 15 degrees, they won't perform surgery. but greater than that, surgery or bracing may be advised. Bottom line, can we massage kyphosis, lordosis, or scoliosis? Well, massage is indicated for treatment because massage is not going to be able to fix it. This is one of those can't hurt it, can't help it conditions. The disposition for those three conditions is indicated, letter I. Next up, we have bunions. Formal name for a bunion is a hallux valgus. A bunion is a medial displacement deviating toward your midline of the first metatarsophalangeal joint, or first MTP joint. Stages of the disorder classified. You can see the images in your books of stage 1, 2, 3, and 4. Stages 3 and 4 have the big toe crossing the second. This condition is more common in women than in men. This is largely due to the footwear that women wear in our society. High heels and very pointed toe shoes will exacerbate bunions. We do see a bit of that with men increasing in our society as Italian pointed shoes are very in fashion still, apparently. A bunion may also affect the fifth metatarsophalangeal joint, referring to the little toe. What is the little toe? We call that a bunionette. It's a little bunion on the side, hardly worth your trouble. It's a bunionette. Etiology. Causes are most likely either genetic, your parents had bunions, therefore you do. We see that a lot of folks of Middle Eastern derivation, or as a result of malforming footwear. There's those high heels, pointy shoes, narrow toe boxes, etc. Signs and symptoms, pain and swelling, calluses may develop, as well as a malformed joint. Treatment for bunions in Western medicine, switching shoes, putting in pads or insoles, possibly orthotics and analgesics. Ultimately, at stage 3 or stage 4, surgery may be advised. Bottom line, can you work on a bunion? Massage to bunions is limited. You're not supposed to do any range of motion. You shouldn't put any direct pressure on the joint. A little effleurage is fine. Focus your work on associated muscles and counteracting any ischemia that may occur. Do not try and move the toe to where it's supposed to be. That is not our job. Some folks may start using toe dividers like they may have in your pedicure office. That's for them to use, not for you. Maintain the caution and avoid excess pressure on this particular condition. Next come hammer toes and mallet toes. These are joint deformities due to chronic irritation. Hammer toes and mallet toes are almost exclusively caused by shoes that are too short. You're trying to wedge your feet into shoes that are not long enough for your foot. It's much less of a problem now than it was 30, 40 years ago. There was an aesthetic back in the 1950s and 60s. Women at that time were afraid of their long feet, and they were trying to wear shoes that were too short, thinking it made them look more delicate when actually it just damaged their feet. Hammer toes have an abnormally flexed proximal interphalangeal joint, whereas mallet toes have an abnormally flexed distal interphalangeal joint. This most commonly occurs to the second toe on either foot because for a number of folks in our society, the second toe is actually longer than the big toe. Not for everybody. Feel free to check your own feet on your own time, but for many of your clients, you will find that second toe to be larger. Longer, anyway. These conditions are often caused by shoes that are too short or have a narrow toe box. Whenever you're contorting the foot into a smaller space, these can develop. They can also occur for genetic reasons. Some people are predisposed to them, as well as injuries or fractures, kicking something way too hard, like the big concrete balls outside some Target stores. And rheumatoid arthritis can also get you here as well. Signs and symptoms: localized pain and swelling. Corns. Corns are calluses that appear on the tops of the toes. They're called corns because they look like, well, corn. Pieces of corn stuck to the feet. Yes, not great. They may develop as well as a big old fat pad callus on the ball of the foot as well. We definitely see this with the usage of high heels. Treatment in Western medicine: wear different shoes. Really simple. Use pads, insoles, analgesics, steroids may be needed, and in extreme cases, surgery. Bottom line, can you massage it? Well, what was the disposition for a bunion? That was a caution. As with bunions, massage may be performed, but any range of motion or stretching of the stretching of the toes, haha, look at that. Stretching of the toes should be avoided. Active stretching can lead to tears or damage to the tissue. This is a caution for said reasons. Last two conditions of the day are pes planus and pes cavus. These are Latin words. Pes planus and pes cavus are abnormalities of the arches of the foot. Pes meaning foot, planus means flat. So pes planus is another way of saying flat feet. Pes cavus, cavus means like a cave, refers to high arches. Both specifically affect the medial longitudinal arch of the foot, whether it is high or low. Planus is much more common than cavus. Sometimes planus is congenital. Some folks are born with flat feet. Some jobs will lead you to develop flat feet, specifically police officers, notoriously, who don't wear terrific shoes and are on their feet 8 to 10 to 12 hours a day, are sometimes referred to, slangily from the 1950s, as a flat foot for that reason. Pes cavus we see in individuals who develop that arch to its endmost point. Folks who do that are traditionally ballet dancers. They are much more likely to have high arches than your average population. Etiology can be congenital, potentially, or caused by certain neurological stresses. Sometimes neurological issues can occur. Planus may also result from prolonged stress due to the foot due to poor footwear. The falling of arches may lead to them eventually being flat. Excess activity or certain conditions such as arthritis and diabetes. There may be some possible foot, ankle, or knee pain or some possible calluses, but neither of these conditions is inherently damage. It is merely a deviation of structure. Flat feet can lead to more shock up the legs, as can high arches. So there is the risk of further injury, but not exactly. Analgesics or surgery advised, but only in the most of acute cases for these conditions. Bottom line, can we massage them? This falls under the lordosis, kyphosis, scoliosis category. We can't hurt it. We can't help it. We're just fine to work on it. Therefore, pes planus or pes cavus is considered indicated. Very good. One last bit of information here. Those 4 words I had you write down, you're going to write them down in answer 4 on your homework. If you can answer the question, please write the correct answer on the back of your homework and fold your homework sheet so that the word is not visible to the class. I will give extra credit for people who answered that correctly, and it is not exposed. If anyone exposes it, if anybody shows that to anybody else, no one gets extra credit. So make sure you hide that correct answer to the best of your ability. Next week, we have more musculoskeletal conditions, more quizzing, more learning, more for the rest of the term. Very good. That was our lecture for today's class. If you have any questions out there, feel free to text me. I am easily textable at my phone number. Feel free to reach out to me with any questions. Class should happen at the normal time next week. The following week, everything should be normal. And again, if you are not able to do this class or were unable to do the online class, I will tell you before that you may also have attended the previous class on the Wednesday, Patho 1. So again, reach out to me if you have any questions. Thank you very much for listening to me today, and I will see you next week. Be well, friends.